Good morning, good afternoon, depending on where you are in the world. It's my absolute pleasure to welcome you to a very special edition of our IPC Partners Journal Club. We've partnered with our American cousins to bring you this journal club, and we've got a combination of great speakers today. We've had a couple of technical issues. IT is wonderful when it works, and then it's the worst thing in the world when it doesn't. But we're going to take you through a couple of papers. And our partnership today is with collaboration with IPC Launch, ID Watch, and the Healthcare Hygiene magazine. And a very warm welcome to Ericka and Ed, who'll be joining us later. We're going to be talking about optimizing prevention and treatment of gastrointestinal and urinary tract infections. Before I hand over to John, I'll just give you a little bit of an overview of what our journal club is designed to do. If you're new to the IPC Partners Journal Club, we've been running these journal clubs now for quite some time. I think we're on to maybe our 25th, 26th journal club. The idea of the journal club really is to try and bring together people with an interest in infection prevention control and the prevention of healthcare associated infections and their transmission. And ideally, we want to try and generate a bit of conversation, bring together a network of enthusiasts who are interested in new research and how they may play a role in new solutions or technologies to reduce their transmission. We also like to have a bit of fun as well. And like we say, we're recording all of these events and we also make them available on our YouTube channel so you can catch up with all the previous recordings. So yeah, it's a real privilege to partner with the team in America today. We're going to split the presentation into two. John's going to kick us off with his paper, and then hopefully we'll bring in Ed to talk about the second element within this. So John, without further ado, welcome, and it's over to you.
Yeah, hi Phil, hello Ericka, and hi Ed, I hope you can hear us. You should be in as a presenter now. I just thought hey Ericka, before you go off camera, I just thought it might be interesting to kick off with a question because we think a lot about urinary tract infections and gastrointestinal infections, but I thought it might be interesting to get a bit of international perspective on the barriers to good prevention strategies around either UTI or gastrointestinal infections. I mean, I've got ideas of my own, I'll throw them in, but I'd be really interested to hear your views, Phil and Ericka and Ed, if you can hear us and see us, hopefully, about what are the key barriers in your world, your view, to the prevention of these infections that are so common in our patients?
Phil, do you want to kick it off?
You go for it, Ericka. You're our guest.
All right. Okay. Well, thank you very much. It's very nice to be here. So, there are numerous barriers that are in existence. Some of the common things we can say are education or access to the right material at the right time. I think that, the fact that Foley catheters are used and maybe not discontinued in an appropriate amount of time has always been a challenge. So, as we move forward and read along with you, John and Ed, about these different articles, I think we'll have a better idea of what others are coming up with. But, what I've seen from the floor is that it's hard sometimes to get the catheters out for a variety of reasons. And we know that the longer the catheters are inserted, the higher the risk factor for infections.
Yeah, here, agree with that. Phil, do you want to throw something in?
No, I think it's a great answer. I think to just back up what Ericka said, I think that there's a lot more that we can do around the education of our clinical staff, around the better management of devices like that. I've seen some really interesting and exciting kind of initiatives in the UK, talking about ensuring that the catheters aren't left in for longer than they need to be. Introducing things like catheter passports as well. So you're talking about the care and management of those patients and their catheters, and just trying to overall just increase that awareness for our clinical staff, that once those catheters are in, for example, do they need to be in for as long, and then when do you actually take them out, and trying to maybe overcome some of those barriers that people think that, well, the catheter's in, it's going to stay in for until the patient's discharged. That might not be the case. So I think there's a lot to do around that kind of education and awareness of the better management of the devices that can lead to a lot of these infections like UTIs.
Yeah, I couldn't agree more. I mean, device management is so crucial for all infectious consequences. Just in case urinary. Hey, Ed, can you hear us?
I can hear you.
Yes, we got Ed in. Congratulations to us.
Yeah.
So I don't know what.
I'm sorry. I was going to add something to. I think that we need to think of prevention in a broader sense, and I look at it as a three-legged stool. One, of course, is prevention. You mentioned catheters. By the way, there's a lot of non-catheter related UTIs that occur that we're now just beginning to address about what some of the prevention strategies might be. The second, which I think we forget about, and it's really linked, and that's diagnostic stewardship, making sure that the patient really has the infection. And then the third part of that, which is linked to that, is antimicrobial stewardship. If we're going to be successful in this space, you need to combine all three of these in a synergistic way to make sure that the right test gets submitted, that the diagnosis is correct. And if there's a prevention strategy that we know is evidence-based, that we try to do that on every patient and every day, which, by the way, I will tell you is not that easy. But nonetheless, I think we shouldn't be looking at this in silos. We should be looking at this more horizontally.
Oh, that's a great comment, and actually links in with what I was thinking of saying. So yeah, I device management absolutely crucial. So often you have just in case urinary catheterization and convenience urinary catheterization. If we get rid of those and just only catheterize when we really need to, I'm sure we'd reduce our device-related infections. But actually, what I wanted to talk about, which I think is probably a universal global challenge, is bowel habit. We don't track bowel habit as well as we should do, and that makes it really hard to make that initial symptomatic diagnosis of a GI infection. And that leads into diagnostic stewardship. Are we oversampling? Are we undersampling? And I think if we had a better idea of bowel habit and more clarity around when we say, yes, this is tipped to balance into non-normal, we need to take a sample. It's not a sample just in case. It's not a sample from an asymptomatic patient, but it's a sample because we think they have an infection, and therefore we're going to actually isolate them at the point the sample is taken and not wait for it to be resulted for 2 days and then spread a GI bug around the ward and around the hospital. So I think that kind of early symptom detection of GI infection is a really key barrier, and something that I've heard people talk about with energy and enthusiasm all around the world. Okay, so I'm going to kick off then. So let me move on to the study that we're talking about today. So this is a really, really interesting randomized controlled trial of the use of oral vancomycin for the prevention of recurrent C. diff infection, just published in JAMA Open Network. I really enjoyed reading the study, but I think my conclusion, and I'm going to cut to the chase, is that oral vancomycin isn't really a goer for the prevention of recurrent C. diff infection, apart from a few quite specific circumstances. So let me explain my understanding of the paper and what's drawn me to that conclusion. So it's certainly true that C. diff infection is much less of an issue in the UK than it once was. But there is interesting evidence that recently we have seen an increase, and nobody really knows why that is. It's been a post-COVID thing and may well be related to something Ed's kicked us off with around antimicrobial stewardship. That being said, in the UK, CDI prevalence remains really high elsewhere in the world. Some of the figures are eye-watering. Probably more important than any of that is that surveillance systems are inadequate. So I think there's a chronic underreporting of C. diff infection. Around a third of patients who develop CDI will develop at least one recurrence, and some patients have really terrible stories of multiple serial episodes of recurrence. Fecal colonization with C. diff is to a larger extent beyond our understanding. And part of that is because we rarely actually do asymptomatic sampling for C. diff colonization. It's just not a thing we do. It's probably not cost effective to do it, even though it might help to prevent C. diff infections. And just by way of background, and this is leading us towards my conclusion, all antibiotics have a downside, and that's for the individual, for the healthcare system, as an individual system, but also as a society. So I would need really compelling evidence to recommend antibiotic prophylaxis to prevent recurrent CD, which is ultimately an antibiotic-associated infection. So, as I mentioned previously, this was a randomized controlled trial, so a really, really nicely and tightly controlled design. It was a US-based multi-center placebo-controlled trial looking at the effect of oral vancomycin prophylaxis on recurrent C. diff incidence. They also monitored VRE carriage in the gut of patients following an episode of CDI. The primary outcome was the incidence of CDI following the initial case that made the patient eligible for the study. And the secondary outcome was VRE carriage using self-collected samples that were sent to a couple of hub laboratories linked to the trial. So this is the kind of main primary outcome and secondary outcomes summarized on this table. A total of 81 patients were randomized. This was fewer than the authors intended because of issues due to COVID and funding. They were aiming for, I think it was 150, and they found that the incidence of C. diff infection recurrence within their 8-week monitoring period was lower in patients taking oral vancomycin, 44% versus 57% in patients on the placebo. So an absolute percentage difference of 13.5 percentage points, but it was not statistically significant. So we can't rule out the possibility that that difference was purely due to chance. The main secondary outcome was looking at VRE carriage, and they found that at the third visit point, VRE carriage was significantly higher in the oral vancomycin patient group than in the placebo. And look at that, 50% of the patients in that oral vancomycin group carried VRE. There's a nuance to the VRE colonization figures in that the real story is that the placebo VRE carriage decreased and the oral vancomycin stayed about the same. So I think there are some questions about how we interpret that. So looking in a bit more detail at the primary outcome from a couple of different angles, they also looked at the risk or the probability of recurrent C. diff by day for patients in the two study groups. And you can see from that Kaplan-Meier plot, there was a difference in the placebo versus the oral vancomycin that's quite visually clear, but it didn't quite get to the statistical significance. And, you know, we can talk afterwards about how we interpret a p-value of 0.06. I'm sure there's been books written on that before. They also did various sub-analyses, as you'd expect in a trial of this kind. It didn't find anything significant in terms of intention to treat populations or high-risk patient groups or the different study sites. So I think overall, the primary outcome was not met. I think that's the summary take-home really here. So strengths and limitations. This is a placebo-controlled RCT, so you can't really get a better, tighter study design than this. And they had, I think, as you'd expect with a study of this kind, comprehensive inclusion and exclusion criteria that seem to be applied as rigorously as you would hope. In terms of limitations, though, and this is kind of a limitation of necessity, they only evaluated one dose and one duration of therapy, and it's quite difficult to conceive how they could do anything different without doubling the size of the study, and they couldn't even get their recruitment target with a single dose and a single duration. So I think that's just an inherent limitation of the approach taken here. As I mentioned earlier, they did have incomplete recruitment, so only 80 of their target 150 patients were enrolled. They didn't look at the wider impact on the gut microbiome either, and it would have been good to see more of a metagenomic approach, I think, in the current era to gut microbiome perturbation or impact from the oral vancomycin versus placebo. VRE carriage alone, based on self-collected samples is a pretty blunt instrument to evaluate impact on the gut microbiome. So what are the points for discussion here? Well, I mentioned right at the start, we'd expect to see a rate of recurrence for C. diff infection of around about a third. In this study, it was high. It was 44% for vanc and 57% for placebo. But remember, the patients were selected into this trial. So the inclusion criteria is that they were on systemic antibiotics for an infection. So many of these patients were already on the kind of high-risk group antibiotics for C. diff. The national international guideline position, I think, probably does reflect the evidence pretty well on the use of antibiotic prophylaxis to prevent recurrent C. diff infection, or the lack of it thereof. In fact, the NICE guidance in the UK says just don't use antibiotics to prevent C. diff, full stop. There's some guidance, I think it was the ECDC guidance, that suggested there are some specific high-risk patient groups where you may want to consider antibiotic prophylaxis to prevent recurrent C. diff. So there is the beginnings of a guideline position, but it's not a commonly held position. Despite that, and this was really interesting, one of the most interesting parts of the study for me, there was already some evidence from the study that vanc prophylaxis, or certainly vancomycin therapy, is really very common out there, in that 40% of the 470 patients who were eligible initially were excluded on the basis of already being on vanc and not wanting to be randomized off it. So I didn't look into the study to see whether there were any differences in the indication for that vanc, but that's a pretty significant chunk of the patients on vanc to begin with. The findings on VRE are somewhat equivocal. I mentioned in the limitations I would have liked to have seen a broader, fuller picture of the impact of antibiotic therapy on the gut of these patients. And I think, just by way of discussion, really, there are other approaches that we can look at to prevent recurrent C. diff that don't rely on prophylactic antibiotics. So, for example, fecal microbiota transplantation, also possibly probiotics, maybe prebiotics. So looking at a way to sort of steward the gut microbiome rather than use antibiotics to prevent antibiotic associated infection. So take home, what does it mean? So this definitely reinforces that antibiotic usage drives antibiotic resistance. That's just true. And I think my take home from reading this paper is that there's not strong enough evidence to recommend vancomycin prophylaxis to prevent recurrent C. diff infection. So I am really interested to see what others think about this one. On your screen, there are two boxes. You've got a Q&A box, which is where we'd love you to put your questions, and also some chat if you have a general comment. So please do get the Q&A started, and I'm looking forward to hearing what people think.
Thanks, John. I really enjoyed that presentation. And just to second what John said there, if you've got questions for John, please pop them in the Q&A. And if you want to have any reflections, you can put them just in the chat box as well. Maybe to kick things off, John, just looking at my questions, you're talking about how the study didn't meet the required number of participants. Did they give any kind of feedback into the study about why that was?
Kind of high level, yeah. So there was reference to the COVID pandemic. I forget the exact recruitment dates, but I think this was certainly COVID era, and everything was hard during COVID, wasn't it? But especially recruitment to clinical trials. They also mentioned funding challenges, so I suspect they got to the end of the COVID window, realised they hadn't hit their target, had the infrastructure to do more, but it would have costed more, and the funder said no thanks, I'm not willing to invest any more in this. So it's quite tantalising, because you felt like they were on the brink of finding something significant, and that may have shifted the needle a little bit, but it wasn't to be. And the study was ultimately underpowered, so I think it's quite difficult to make a really firm conclusion.
Yeah, you're right. and it's, the statistical significance was nearly there, wasn't it? And we can scrutinize over the p-value, I'm sure, at length. There's some comments, and so there's a comment here from Josephine Arthur. Says, I've always advocated for probiotics for patients on antimicrobial therapy, even as a recommendation from a C. diff dissertation when doing an MSc in infection control. That's really, really interesting. I want to come on to probiotics and prebiotics, actually, John. Maybe just for the audience, what's your definition for probiotics versus prebiotics? How do the two differ?
Yeah, so probiotic, my understanding is that it's trying to provide a live microbe to repopulate a microbiome that's been disturbed by something, by therapy or by a change in circumstance. A prebiotic is a precursor drug that is introduced in a way that the metabolic changes in the gut activate it somehow. Yeah, so I think both of those approaches could potentially be used to prevent recurrent C. diff infection.
Yeah, definitely. Just really keen to understand the differences between them, and they're quite subtle, I guess, aren't they?
Yeah.
There's also another comment saying about there's also a need to prescribers to review PPIs, enteral feeding, etc. patients who are antimicrobial therapies and those on antimicrobial therapy that are at risk of C. diff due to their medical history and medication, which again is a really good, valid point, isn't it?
Yeah, completely. I mean, we need to look at this as a whole. I mean, this study was a cluster randomized controlled trial, so they were able to look at a relatively unbiased patient population and take out those kind of potential confounders like PPIs or enteral feeding or other antimicrobial therapies. I can't actually recall exactly the things they looked at, but they'd have been stupid not to look at PPIs as a potential confounder here. So because of that nice, neat study design, they were able to take out these confounders. But from an individual prescriber point of view, absolutely, we need to keep all of those things in mind when deciding on therapy.
Mm-hmm. Just for those in the audience, if people have got questions around, other things that John has talked about, like FMT, prebiotics, and their experiences of them in the management of certain infections like C. diff, we'd love to hear them as well. I wanted to ask you about FMT, John, because you talked a little bit about some of the kind of alternatives there are for the management of some of these infections. What's your view on FMT and whether or not it's got a role in things like preventing recurrent C. diff infection or for the treatment of people who've had antibiotics?
Yeah, so there's the remarkable initial kind of debut of FMT with that New England Journal of Medicine paper many years ago now that showed that for treating recurrent C. diff infection, FMT knocks spots off conventional antibiotic therapy, and that certainly gave us a bit of a wake-up call to say, well, this is remarkable. I don't think anybody would have predicted the outcome of that study. It was halted early because it was so successful. Could it be useful for preventing recurrent C. diff infection? That's a different indications, not treating recurrent infection, but rather preventing recurrent infection. I feel like there's a good chance that it could, and I think there's a lot of potential benefits with going for a non-antibiotic approach. As I mentioned right at the start, antibiotics always have downsides, whatever the scenario may be. That you're always going to have unintended consequences with an antibiotic, and of course, any therapeutic intervention, FMT, probiotics, prebiotics, will have unintended consequences. But I feel like certainly from a societal point of view, nothing has the unintended consequences to the level that an antibiotic does.
Yeah, that's a really good point, and I couldn't agree more. And it is interesting to think about how long ago that paper on FMT in the New England Journal of Medicine was now. It feels like a long, long time ago.
2013, is that right? Have I made that up?
I think you're right.
Like
I think you're right. Yeah, which,
that's
to say
22 years ago, Phil.
I feel old.
Yeah.
A final question, and then we'll move over to Ericka to introduce Ed. You talked a little bit about maybe one of the limitations is that in the era that we're in now, from an infection control perspective, and the advent of metagenomics, both for things like investigation of outbreaks and trying to manage infections, You talked about metagenomics of the gut to see the impact. I thought that would have been a really interesting addition as well. Yeah, maybe that's something, again, obviously it's all reliant on funding, isn't it? But it would have been a really interesting addition, wouldn't it?
It would have added a whole another dimension. I suppose the problems that are introduced are it's relatively expensive to do, although much less than it was. And I think how to interpret it is also important to consider, because there's not, a standard interpretation of gut perturbation from a microbiomic point of view. So I think it would have added complexity to the project, but I do feel it would have been well worth doing. I think it would have strengthened the case for not introducing prophylactic vancomycin to prevent recurrent C. diff infection, because I think, as I mentioned, VRE colonization is a blunt instrument, and I suspect there was much more significant impact on the gut microbiome that wasn't picked up with that measurement.
Yeah, definitely. Okay. Before I come to Ericka, there's just a couple of comments. One is around the issue with probiotics and the fact there are different strengths, and no one can decide what the best strength is for patients to prevent C. diff. That's a really important consideration. And Ed saying that there are studies also showing that
it's not a strength. I mean, probiotic, it's not as if there's a single probiotic. There's a whole
of course
realm of potential cocktails of microbes you could choose. So it's strength, but also composition as well.
Yeah, very good point. And what is the right one? And Ed says there's studies also showing increasing MIC for treatment failures, and FMT may also help with decolonization for MDROs as well. Really interesting point.
Yeah, I agree.
Okay.
Although the initial data on decolonization, I was hoping that this was going to really solve some of our issues. Actually, that if we have a patient with MRSA colonization, VRE sitting in hospital for 6 months, or usually not that long, 6 weeks, give them an FMT and hey presto, they're decolonized. I don't think it's going to be that straightforward, but I still remain really optimistic around the prospects of FMT in general.
Great. Thanks, John. We'll probably hear from you again towards the end. I'm delighted now to hand over to Ericka, who's going to introduce our next speaker. Ed, if you just give us an okay when you want us to advance slides, and we can do that for you, no problem.
All right. Well,
nice to me.
I have the pleasure of introducing Ed Septimus. He is a board-certified physician in both internal medicine and infectious diseases. He was the VP of Research and Infectious Diseases at HCA Healthcare until 2018. He has served on the board of directors of the Infectious Disease Society of America, IDSA, and was on the IDSA Antimicrobial Resistance Committee, the SHEA Antimicrobial Stewardship Committee, as well as the IDSA Quality Measurement Committee. He now serves on the IDSA Sepsis Advisory Panel. He currently holds a faculty position as professor at Texas A&M College of Medicine, senior lecturer, Department of Population Medicine at Harvard Medical School, and adjunct professor of medicine at Houston Methodist Research Institute. He has received multiple teacher awards, and he has over 140 articles and chapters that he has published. So, Ed, thank you for joining us today.
Well, thanks for the opportunity. I really have an exciting part to present that really is very complementary to what we've been discussing. And the Infectious Disease Society finally has published their guidelines on the management and treatment of complicated urinary tract infections. It's been over a decade since IDSA has published any guidelines on urinary tract infections, so this was badly needed. So if we go to the next slide, they start with classification. So the old classification for uncomplicated UTIs were primarily acute cystitis and afebrile, non-pregnant and premenopausal women with no diabetes and no urological abnormalities. They've cleaned that definition up very significantly. And so uncomplicated UTIs are an infection that's confined to the bladder. In afebrile men and women, you don't see anything about underlying problems. You don't see anything about urological abnormalities. But if you've got a bladder infection without fever, that's uncomplicated. On the old classification for complicated, they divided it up between acute pyelonephritis and then all other complicated UTIs. In the new classification, you can see they lump together pyelonephritis, bacteremic UTIs, catheter-associated UTIs or CAUTIs, which most of them are febrile if they're significant, and prostatitis, which is really not covered in these guidelines, but I will tell you that there's a recent publication that actually is a review of the diagnosis and treatment of prostatitis, which is a discussion for another day. So if we can see the next slide. So I'm going to start off with the key recommendations, and then I'll drill down on a couple of areas I think that may be important. First of all is selecting empiric antimicrobial therapy. And they really have a very nice step-down approach to looking at how severe is the patient, what are the risk factors for resistance, what are some of the patient-specific considerations, and they're really around allergies and drug-drug interactions, underlying problems like renal insufficiency, et cetera. And if they're septic, what the local antibiogram shows. Now, let me first tell you what they mean by septic. They're using the sepsis 3 definition, which means you have an infection with some organ dysfunction associated with that. They're not talking about SIRS. They're not talking about the old classification. They're only talking about sepsis 3, which means infection plus organ dysfunction. The preferred options for patients who have sepsis that meet the sepsis 3 definition include extended spectrum cephalosporins. In some cases, carbapenems will tell you where that may fit, piperacillin, tazobactam, or fluoroquinolones. And for patients who aren't septic, who may require a parenteral therapy, there are multiple options, but one option that is not recommended is the use of carbapenem. So this is where stewardship becomes really important. So if we go to the next slide, we'll show the other recommendations that because of concern of resistance, they recommend avoiding fluoroquinolones as empiric therapy, especially if a patient's received that antibiotic class in the previous 12 months. Now, I'm going to sort of give you my take on this, and depending upon where you are in the country, if we are talking about the United States, most institutions, and we're talking about E. coli being the most common pathogen for urinary tract infection, the resistance rates to fluoroquinolones are around 20 to 30+% to E. coli. So in my opinion, I would have liked to have seen the guidelines say that fluoroquinolones for empiric therapy probably should not be recommended. That's my opinion. Now, you may be in a country or an institution where you have much higher levels of fluoroquinolone susceptibilities, but as you know, that drug has been overused and resistance is a problem in many areas of the world. So that's one consideration that I would have liked to have seen it worded a little differently. And we'll come back and talk about resistance and how long back you should go. Patients who initially see parenteral therapy should be switched to an active oral agent as quickly as possible, providing the patients can take oral medication, and of course the organism is susceptible to the oral medication in question. I think this is really important. We've gotten much better at going from IV to PO. It gets the IV out, cuts down on complications, gets the patient out of the hospital earlier, and there's no compromise in terms of patient outcomes. And then the last bullet point, which is important, as in many other common clinical syndromes, we're going to shorter and shorter duration of therapy. So for most, if you have a fluoroquinolone susceptible strain, most of the studies show for complicated UTIs that you can treat for as few as 5 to 7 days. And for non-fluoroquinolones or beta-lactams, 7 days appears to be just as good as longer duration, including, and here's an important consideration, including those who have associated gram-negative bacteremia, providing there isn't a source control issue, which I'll talk about in a minute. So really an important consideration, shorter duration of therapy, switch from IV to PO as soon as the patient's stable. Next slide. Now, this is a nice little algorithm they came up with. So here's the patient has a complicated UTI at the top. You evaluate the severity of illness. Now, if the patient's in shock, so that's the sepsis 3 definition, plus the patient's in shock, you want to evaluate the risk for resistant organisms. There's some nice discussion in this guideline talking about how far back you go. So many of you probably know if you have an electronic health record and someone had an ESBL cultured 2 to 3 years ago, Do I need to consider that in my empiric therapy? And what the guideline says and what the literature says, that the longer you go from that infection, the less likely the patient remains colonized with that MDRO. In fact, this particular guideline talks about 3 to 6 months. There's data for ESBL looking at 6 to 8 months. And so what I like to tell clinicians to make them feel comfortable, if you've got an MDRO that's greater than a year from the time the patient presents now, that you don't have to necessarily take that into account, and always give meropenem if they had an ESBL 2 years ago. I think that's an important consideration in terms of stewardship. We mentioned the patient-specific factors in terms of drug allergies, drug interactions, et cetera. And here's another important caveat. If they're in shock, not just sepsis 3, but sepsis 3 plus shock, look at your local antibiogram. They recommend a threshold of choosing an agent that has greater than 90% susceptibility. And that'll vary depending upon the institution that you're at. So look at your antibiogram. If you're lucky enough to be able to look at what's hospital onset versus what's community onset, if you can do a syndromic antibiogram, just looking at urine isolates, you can get very sophisticated in helping recommend what the best agent is. So in my institution, that greater than 90% susceptibility for E. coli, for patients with complicated UTI, we're going to select actually a carbapenem, because our third generation or extended spectrum cephalosporin susceptibility is in the range of around 80 to 85%, or it doesn't meet that 90% threshold. On the other hand, if the patient's not in shock, they recommend greater than 80%, in which case most of those patients can be treated with an extended cephalosporin, reserving carbapenems for those patients who truly need it. And that's going to have importance in terms of the microbiome, resistance, and selection out of even worse organisms. And if the patient's not septic, you have much more leniency in terms of what antibiotic to give, and you have more time to make sure you get it right, because the mortality rate in non-septic patients is extremely low. Next slide. And then again, switching from IV to PO, I want to pay a little bit of attention to the right-hand side of this algorithm. If the patient's not improving, what do you do? Well, one thing, you want to make sure you don't have a drug-bug mismatch. Now, in order to do that, you have to do everything you possibly can to make sure you culture the patient before they receive an antimicrobial agent, so you can recover the organism, so you can do more targeted therapy. Otherwise, if the patient gets an antibiotic, they rush it in the ED, they forget to get the urine culture, the patient's getting better, or if the patient's not getting better, you don't know whether or not you have the right drug or not. Also look for unresolved sources. So if the patient has an obstructing stone, the patient has an intrarenal or perinephric abscess, that's a source control issue that also may affect the patient's response. So you need to reassess the diagnosis, do the appropriate imaging studies, and those patients may require a longer duration of therapy. On the other side, which is the vast majority of patients, they clinically get better. We recover the pathogen. We look at what oral options are available. We switch as soon as we can to an oral agent, and we treat for a maximum of 7 days. Next slide. Okay, so we've already mentioned about the timing. As soon as the patient's clinically improving, their GI tract is working, you have the susceptibilities, you have an oral option, I suggest that you switch to an oral agent as quickly as possible. It's effective, it gets the IV out, gets the patient up and ambulating and out. The next slide shows you some of the oral options. And this may surprise a few. I like this chart that they put in here, because this may or may not be familiar to some of you. The common oral agents that we use have varying degrees of oral absorption and urinary excretion. Remember, the site of the infection is the kidney in most cases. So if you look at amoxicillin as an example, it gets pretty good absorption, pretty good urinary excretion. And then you look at a variety of cephalosporins, and they're quite variable. For instance, cefopoxidine or Vantin gets pretty good absorption, gets very, very high urinary excretion, over 80%. And then you look at a first generation cephalosporin like cephalexin, tremendous absorption, and very, very high urinary excretion. Now, if it's susceptible to a first-generation cephalosporin and the patient's systemic symptoms are improving, one of the options is to use high-dose cephalexin therapy. And you'll notice the doses there on the right are a little higher than perhaps you're familiar with. But there's some very nice studies showing, even though we don't recommend cephalexin for patients who have complicated UTIs, when the patient's clinically improving, their bacteremia is cleared if they're bacteremic, using high-dose cephalexin as a step-down therapy is an option because of its high oral absorption and its very high urinary excretion. If you look at fluoroquinolones, I've already mentioned I would not use them unless you know they're susceptible, but they really have very nice urinary excretion. You'll notice that Cipro is much lower than levofloxacin. And the reason for that is that part of Cipro is cleared by the liver, whereas all of levofloxacin is cleared in the urine. And then, of course, there's the trimethoprim sulfamethoxazole, good oral absorption, really nice high concentrations in the urine. So those are some of the options you have. There are other cephalosporins, so ceftinir, which does not get the same absorption and the same urinary concentration that cefoxidime does, which is Vantin. And so there's a debate as to which one of those you should use. If you need a third-generation cephalosporin, which might be a patient has an E. coli that's resistant to first generation but susceptible to third and fourth generation, which of the extended spectrum oral cephalosporin should you use? Next slide. And again, patient presenting again with pyelo, we've already mentioned to this, with complicated UTIs, 5 to 7 days is the recommended duration. There's a little less data for short course with oral beta-lactams. As I mentioned, part of that has to do with the dose that they use. And as I mentioned in the previous slide, you'll notice that some of the doses are perhaps a little bit higher than what you're accustomed to. The other thing is the duration of therapy is counted from the first day of effective therapy. So if you choose agent A, it turns out resistant, and you change to agent B, the first day is when you start that agent B, which is effective against the pathogen. Next slide. A lot of the studies, as mentioned, do not always include people who have abscesses, obstruction. We mentioned prostatitis is not included in this. So some of these patients, the duration of therapy may have to be individualized to some of these high-risk conditions. Also, there's some data in the last year or two that show that men with febrile UTIs, with or without prostatitis, benefit probably from a little longer duration of therapy, and the guidelines point out 10 to 14 days. And again, the other thing that the guideline points out is that if you have bacteremia, a lot of questions, well, if they're bacteremic, do I need to treat them longer? Then if they're not bacteremic, there's now a whole number of studies that show that, in fact, bacteremic disease gets treated for the same duration of therapy as non-bacteremic. And again, 5 to 7 days is the recommended duration. Next slide. Now, I want to conclude with these two statements on this particular slide. One is the guideline doesn't include imaging. I am told that there will be a follow-up that will discuss the appropriate use of imaging for patients who come in with suspected complicated UTIs. In other words, does everyone who has a complicated UTI need a CT scan to look for an abscess or stone? That's not mentioned in this guideline. And the one thing that I really am distressed about, and I've alluded to this from a comment at the beginning of this podcast, is there's no discussion about urinary diagnostic stewardship. One of the things that's very frustrating is see a patient come in with something unrelated, gets a urinalysis done for reasons that are unclear. The urinalysis comes back with pyuria and bacteria. And as a clinician, you're always drawn to a positive result. And so a lot of patients who really have asymptomatic bacteria now get included as having a possible urinary tract infection, and they get treated. So I think we need to have a really better discussion. I think number one is how you make the diagnosis. What are the symptoms that are suggestive of a urinary tract infection? Should we be screening all urines for pyuria before we culture them? These are important considerations, I think, in making the diagnosis, because patients come in, they're confused, they're altered, they may have dementia, underlying dementia, they're very difficult, but they may not have any Y count, they may not have any fever, and yet we're compelled to do a urine, and the urine comes back positive and the patient gets treated. And then what ends up happening is it's like circling the drain, because we give them one antibiotic, they come back with a more resistant one the next time. And this is a cycle that we need to break. And that's why I mentioned earlier the importance of not only looking at the patient clinically, but making sure we do the right test, making sure if it is a urinary tract infection, we culture the patient before we start antibiotics so we can recover the pathogen, and then we can do more targeted therapy on that patient, and hopefully IV to PO if appropriate. So I think this is an exciting guideline, and I think it's a really great start, and it's such a common diagnosis that I think it'd be wise for all of us, all of our institutions, to discuss this, talk to our emergency room folks, especially because a lot of these patients coming through the emergency department, about how we manage these people, what the diagnostic criteria should be, and what empiric therapy is most appropriate. And then on the inpatient side, part of the stewardship component is to make sure when that culture comes back, it is an opportunity to de-escalate. We should do that as quickly as possible. For every extra dose and every day, a broad spectrum antibiotic increases the risk of adverse events, including acceleration of resistance, C. diff, acute kidney disease, et cetera, all associated with antimicrobial therapy when it's not necessary. So I'll stop there and see if we have any questions.
Thank you so much. That was really very informative. I don't see any questions in the Q&A, but I do have a couple questions that I wanted to ask you. So we talked a little bit about the antibiogram, the local antibiogram. So when I hear that recommendation, that really, it tells me that it's relying on information exchange from facility to facility. So we can look at what the local hospital might have as far as what their resistance patterns are. But what would you say, what if there are hospitals that don't get the information from, say, long-term care facilities that, we know could have additional resistance patterns? So what would you say about that type of a situation?
Well, that's a very difficult situation where some of the electronic health records are now becoming more attached to each other. Epic's become the big gorilla in terms of the United States, in terms of the electronic health record. And so if you're on Epic, regardless of your healthcare system, you now can get insights into the medical records of other institutions. Now, that doesn't answer the question of long-term care. And that's a difficult one. And I think what we try to do is to share information that if a patient's coming from a long-term care facility, especially if you have multiple patients that come from that same place, that you track those resistance patterns of those patients coming from that long-term care facility. But it's very difficult, at least from my experience, to get access to their antibiogram, or even if they produce an antibiogram. Now, nursing homes are probably not going to do that, but long-term acute care may. So we need to have a way to be able to share that and to find out what prior cultures the patients had before the patients transferred to the hospital. So we try to set up those kinds of information, but I have to tell you, on a real-time basis, sometimes, especially if it's after hours, it's difficult to get that information. So I think that's a great question. I think we need to do better in terms of being able to have access to it, because if I have someone coming from a nursing home who really has a complicated UTI, that's going to be a little different patient than someone walking in off the street who's got pyelo, who's not been on antibiotics. And so I think those are two different patients, and that's the patient factors that I mentioned before, which I should have mentioned, is are they city dwellers? Are they coming from long-term care? Are they in nursing homes? That's probably going to impact whether they have a higher likelihood of having an MDRO, but we need a better way to be able to connect those records.
Yeah, another thing to just follow up on that, the one statement that you had in your slides about, if a patient has been treated with a fluoroquinolone in the last 12 months, that they should not be treated with that. And so I'm thinking about, there could be elderly patients coming in who have no idea what they've been on in the last 12 months. You could have people who have gone to urgent care centers, given antibiotics in an outpatient setting in the last 12 months, even looking at dental providers who give, antibiotics sometimes after surgeries or sometimes prophylactically. So I think that's a big question for some of these patients. I mean, I don't know, for myself, have I been on a fuller equivalent in the last 12 months? I'd have to go back and think about it. So, for that being part of the guideline, that really is something that we really are going to need to rely on electronic data communication, but knowing that that is a challenge, because not all data systems communicate with each other. So that's just a follow up to that. And then the other thing
as I said, I'm sure the UK agrees with this because they banned fluoroquinolones a long time ago because of their C. diff problems. But I am very reluctant, except maybe for pneumonia, for the respiratory fluoroquinolones. I'm very reluctant to recommend any empiric therapy with fluoroquinolones, whether it's complicated UTIs or intra-abdominal, until I know what the susceptibility is. So that's the one part of the guideline I'm a little bit uncomfortable about, but I think they were looking globally at much more than just perhaps my facility in making that recommendation. But I'm a little uncomfortable about fluoroquinolones empiric therapy for intra-abdominal and urinary tract infections for the reasons I mentioned.
Yeah. We do have a comment here. It said, did you say gender no longer is used? If yes, can you explain why the new guidelines discourages using gender as a criterion?
They don't use gender as a criteria for uncomplicated UTIs. Okay, gender, diabetes. That the question may come in. We know that diabetic females have a higher incidence of having UTIs, but they're differentiating that between complicated and uncomplicated. So it doesn't matter what your gender is. If you have lower urinary tract symptoms and you're afebrile, that's uncomplicated. It was in the previous guideline. If you had, urinary anatomic abnormalities, if you were diabetic, that was in the previous for uncomplicated. For uncomplicated, you have bladder symptoms and no fever. So it just simplified the definition.
Hey, Ericka, can I throw in a question? So
sure.
Relates to diagnostic stewardship. I think it's a really interesting angle you threw in at the end there. So we've got a problem in that we're both over testing, we're over treating. Do we try to stop over testing, or do we just try to get better at not treating when we have a test result that's positive, but it's actually asymptomatic bacteria?
If there was a really nice study looking at whether diagnostic stewardship or antimicrobial stewardship is more effective in reducing unnecessary treatment for UTIs. And it turned out it was the diagnostic stewardship that was more effective on the front end, okay? So there are systems that have embedded in their electronic health record that the first screen you go to is you have to declare what the patient's symptoms are. And if they don't have any of these symptoms, you can't go on. The problem is there's always an out. There's always an exception, but there are screens where you have to declare a symptom, then you have to use a urinalysis, and then it has to be reflexed only if the patient has pyuria. Now, you can cut down significantly on the number of urines that gets sent if you use that algorithm, but it's not perfect. So I think the whole idea of putting an indication screen in is just to have the clinician think about, does this patient truly have a urinary tract symptom? And if not, to discourage them. There's also a very nice study that talked about urine cultures being done in the emergency room, and the lab did not report the results. And the only way the clinician can find the results is actually to call the lab. And very, very few people actually call the lab to get the results.
I mean, I believe it. And I haven't read that study on diagnostic versus antimicrobial stewardship, but I believe it, because you can't unsee a positive result. And it influences you in that way. So yeah, for sure. Interesting. Thanks.
But and the other whole thing, do you have a soft stop or you have a hard stop? In my experience, and this mentioned C. diff, we had this soft stop that if patient was on laxatives, they shouldn't send the C. diff culture because the diarrhea was probably due to the laxative. But it could be overridden. And so 80% of the time, the physician overrode it. So that gets into the hard stop versus soft stop. And I think obviously hard stops are more effective, but they're also, from a clinician standpoint, less friendly, and a lot of times I don't like it. But I think that's probably what it's going to come to, is to be a little bit more adamant that this patient should not have a urine sent. And the other big thing, especially in the elderly who have dementia, is they get confused. Okay, but we've tried to drum in people's head, if they don't have any fever and they don't have a white count, just because they're confused doesn't mean that they should get a urine. And there's some really nice study that came out that looked at people who had dementia and people who had altered mental status, looking at whether or not they had any symptoms or not, talking about fever and stuff. And if they had no fever and no leukocytosis, and by the way, none of these people had dysuria, and some couldn't tell you that less than 1% of that patient population developed bacteremia. And if they had some fever, only about 3%. And so that was a really powerful study showing that just because they have altered mental status, lots of reasons why people who have dementia and on a lot of different medications, that they can be altered. But if they don't have any systemic signs and symptoms of infection, okay, you probably shouldn't send a urine, because that's the same population that have an increased percentage-wise, increased percentage of people have asymptomatic bacteria. And the other thing I try to tell people, even if you have that pyuria reflex, over 50% of people who have asymptomatic bacteria also have pyuria. So that's not in and of itself going to prevent people from culturing them. So it's a tricky issue, and that's why I mentioned in the beginning, I think diagnostic stewardship has to be integrated into infection prevention and antimicrobial stewardship if we're going to really affect real change over time. And it's very, very hard. Clinicians have a hard time not reacting to a positive lab result. And so if you get that culture in the beginning and it's positive, then it becomes difficult. So those are great questions, and I hope we stimulated some thoughts and conversations.
Thanks very much, Ed. A big thank you, Ericka and Ed, for joining us on this special edition. A big thank you to IPC Launch, ID Watch, and Healthcare Hygiene magazine. I've really enjoyed the conversation, learnt a lot as well, and I hope the audience have as well. So Ericka and Ed, thank you very much for your time. Just in 30 seconds, we've got a really exciting schedule of journal clubs planned for the next couple of weeks and months. As you can see, we've got a really jam-packed schedule with a real range of presenters talking about lots of different areas, from things like hand hygiene right through to kind of environmental hygiene and whole genome sequencing. So we've got a really good selected range of speakers there. A final reminder, you can see this recording on our YouTube channel, where we host all of our recordings on that YouTube channel. And a reminder, this was brought to you from IPC Partners in partnership with IPC Launch, IDD Watch, and Healthcare Hygiene magazine. Ericka and Ed, thanks very much. And thanks, John, as well. And we hope to see you all soon.